To follow those two excellent presentations. Thank you for showing up on a Sunday morning, especially thanks to Tupac and Jewel and everybody for the kind invitation to speak. So I have no disclosures. As one of my pseudo mentors in the field who does have conflicts says, if you don't have conflict, I don't have interest. So hopefully I can still keep your attention. I think I met all this. I am, one of the hats I wear, for those of you familiar with ASTRO, it's the American Society for, the T stands for Targeted Radiation Oncology. So I'm this year's president, and I'm kind of coordinating the meeting in San Francisco where we're going to cover a lot of these topics. The topic is rediscovering radiation medicine, not so much radiation oncology, radiation medicine, and exploring new indications. We'll have a lot of talks on how we can use next generation sequencing and circulating tumor DNA, perhaps circulating tumor ctRNA. And so hopefully if you have an interest and want to see a great American city, come visit us in San Francisco. So we like abbreviations, maybe not as much as medical oncologists, but we'll certainly give them a run for their money. So we'll kind of deconstruct some of these in the next few slides, and then we'll go through hopefully some pretty pictures and fun videos. So radiation therapy for GI tumors, there's a lot of letters here, and a lot of them are actually somewhat irrelevant. They have historical meaning, but now they're all kind of jumbled together, and we'll go through these in the next few slides. But image-guided radiotherapy, IGRT, IMRT, SBRT, ART, PBT. So all of these things can be very confusing, and I'm sure in tumor boards, these are just tossed around by radiation oncologists. Here's the secret. We're trying to confuse you. We want to make you so afraid you never want to come into the basement ever, because we always have like snacks and donuts and coffee, and we don't want to share it with you. So image-guided radiation therapy, really the concept came up, well actually going all the way back to the 50s, but probably really took off about 20 years ago when William Beaumont Hospital was the first place to actually develop cone beam CT. It was the idea of putting a CT, a poor man's CT, onto a linear accelerator, basically where you could shoot the x-rays through that. And that allowed us to localize tumors in real time, really for the first time in a commercially available way. And now we can do it with even MRI, but that's IGRT. And so there were differential codes for this, and so it became labeled IGRT. In GI, it obviously has significant advantages because things move relative to bony anatomy. So we used to set people up relative to bony anatomy. Well, anybody knows that the GI tract moves and it can take the pancreas with it, and so if you set up to external anatomy marks, you could be missing the tumor, and that's why there was a lot of toxicity when we treated GI tumors. This is largely gone. I mean, it's been minimized, not gone, because we can actually localize to the internal anatomy, the target anatomy, what we're trying to hit, and also see what we're trying to avoid. But IGRT now is standard. And it comes part and parcel with IMRT. And so I'm guessing many of you, if not all of you, have heard the term IMRT. What does that mean? And IMRT is also essentially standard, and due to billion coding changes that'll occur probably this summer, will become, I would be surprised if we used anything other than IMRT starting next year. So IMRT, the I is for intensity, but it's also inversely planned. So when we used to do, well, we still do this, called 3D forward plan, we'd have to sit and say, I want to treat this, I'm going to put the beams on in this particular angle, I want to give this structure this amount of dose, but it would be kind of tinkering, put in a field, oh, I'm getting too much dose, maybe to the spinal cord, adjust the angle. So the real key of intensity modulated IMRT is really it's inversely planned. We say, I want to give the pancreas this dose, I want to limit the dose to the small bowel, the stomach, the spinal cord, and we put cost constraints. It used to be actually in real dollar signs, because I guess we do okay financially. And we'd actually put, now you can't say it's 100% give this dose to the tumor and 100% give this to, avoid the spinal cord dose. You have to make compromises. But that's actually, so it's inversely planned, and then it's, beamlets are used to modulate beam intensity. So it's as simple as, remember when you make the bunny ears, with using your fingers, 2 fingers through the flashlight? That's actually intensity modulation. You don't realize it. So we actually will deploy multi-leaf collimators to shape the beam. And so this improves dose conformality, but sometimes can increase the total radiation exposure to the patient. And that was some of the initial concerns with IMRT that have largely gone away in the last 20 years. Stereotactic body radiotherapy incorporates all of this. And so really with SBRT, it's also historical. Really everything we do now is stereotactic body radiotherapy, but in terms of billing vernacular, it's coded differently and paid at a much higher rate. So it pays roughly, depending if you're hospital-based or freestanding, $1,000 to $1,200 a day versus, which is more than double IMRT. So it really has billing consequences, and it has to be 5 fractions or less. But for all practical purposes, there's really not a lot of difference in what we're delivering, whether it's a 5-day course or if it's a 30-day course, in terms of the image guidance or the accuracy or any of that. What is different is the daily codes that are being used to deliver that radiation. But SBRT is also a term, we use it a lot, but essentially it's the same principles. And adaptive radiotherapy is inter or intrafraction alignment. So in that situation where if the tumor is not in the same place today as it was yesterday, we can make adjustments in real time and adjust the plan on the fly. And I'll show you an example. Proton beam is an area that I guess in the land of the blind, the one I man is king, and so I'm an expert in this. I've been doing particle therapy for 25 years when there weren't many centers in the United States. There's still not many, but there's more. This uses protons. What is a proton? It's the H of H2O. It's exactly what's in your glass of water. We take the water, we can split it apart, we can take the hydrogens, they have a positive charge. We can accelerate them using RF chambers, and we put them in a circle, and that's called a cyclotron or a synchrotron. We can give them, so think about this. If you had a car that got 20 miles to the gallon, if you wanted to go 60 miles, you'd put in 3 gallons of gas, and then the car would stop. If you wanted to go 200 miles, you'd put in 10 gallons of gas, and the car would stop. So the advantage of protons is that it stops. Slight disadvantage is we don't know exactly where in some cases, which is one of the things that we're working on, but it can be very good in particular cases to reduce dose to normal tissues. There's biologically targeted molecular radiation, which I think is fascinating. We can actually put in PET tracer and localize to this on a daily basis, but didn't have enough time to get those images in. Theranostics and radiopharmaceuticals, again, something that I see there's, not surprisingly, there's exhibitors. This is going to be a massive market. This is something I work closely with the Society for Nuclear Medicine and Molecular Imaging on. To put it in perspective, radiation oncology is a $4.5 billion field, depending on what you look at. It'll probably grow over the next 10 years. But right now, I think for theranostics, and this kind of value on this slide is probably 4 or 5 billion, but we anticipate it'll be 19 billion globally, with about 35% of that being in the US. So this could very well be bigger than the entire field of radiation oncology. Not all of this will be for oncology, but the vast majority. But there's a lot of, essentially you take a payload and you deliver it based on certain antigens. AI and big data integration, something we're trying to use a lot in radiation. We do a lot of this at Mayo. So we do have machine learning to help predict for toxicities, and we're working actually with 5 different companies to help us actually contour structures. Some of the stuff we're really good at, some of the stuff is really hard. Just recently we had we were doing ovarian avoidance, and finding the ovaries, at least I think, is super hard. We plugged it, we had a partnership, we have a partnership with Google, and so this is something we've got a data set on, and we plugged it through that, and it found it within, obviously nanoseconds. And so there's some really interesting things that we're using in AI and big data. So with that, let's get to some more fun stuff. That was the housekeeping. Hopefully this will be interesting. Now, in full disclosure, we don't have MR-Linac technology at Mayo Clinic. They do it at City of Hope, they do it at MD Anderson. But, fun fact, I am a Series A investor in a company called ViewRay. I have long sold, like more than 10 years, about 10 years ago, of a joke. I use it with protons, but it'll apply here. I'm sure you're all familiar with protons. Do you know how you make $50 million doing proton therapy? You start with 100. And so it's not that much different in MR-Linac technology. This is, if you want, it's a great technology, I think, to treat the appropriate patients. It's also a fantastic way for you to lose money. And I'm an expert in this because I lost my own money. I still think it's a great technology and advocate for it. But these are courtesy of my colleague Michael Chong at Miami Baptist Cancer Institute, which is an early adopter of MR-Linac. So these are his slides, I want to make that clear. So the point on this slide is that people think pancreatic cancer is a systemic problem. But it does appear that there is at least a significant number of people that do die from locally destructive pancreatic cancer, 30%, which is, I think, something that's worth respecting, because that's where obviously we come in as radiation oncologists. There are 2 commercially available linear accelerators. I wasn't clear on what exactly the industry standards were in the talk, so I have them blinded, but I'm happy to talk to you offline. But these are the 2 that are commercially available, and there's one that I anticipate will come shortly. It's in Canada right now, treating, and it's FDA approved in this country, but they haven't had a sale yet. And, obviously there's far superior soft tissue contrast with MRI. That's easy to see on the left versus the right. And this is a 0.35 Tesla MR, which is where I did some of this initial work about 20 years ago as a part of that investment that I made when I was in academia in Florida. Let's see if this works. Yes, hopefully I'll do this one. And this one too. This one's not playing, that's okay. You can kind of see, so what you're seeing here, is there's actually gating. And so you have a target, and hopefully it's showing up pretty well. And this is the system, actually. This is courtesy of Bill Hall, who's at Medical College of Wisconsin, the same system that Dr. Lin has at Anderson. This is a much higher strength Tesla MR. But you can see, this will actually, if your target goes kind of out of phase, the machine can turn off. So you can really shrink down margins, and you can see, I think actually one of the cooler things to watching this is just the heart and how fast it flutters. But so you're taking real-time MR images, and so again, the advantage is that you can really shrink down the margins. You're still using those same principles of intensity modulated radiotherapy, and this is obviously image guidance, but you can adjust this in real time. And so this is some data, again, led by Michael Chong. It's some of the first 5-fraction MR-Linac outcomes data, and compared to historical cohorts, very, very low grade 3 and higher toxicity with excellent control rates and survival at 1 year. And this is their SMART study, and there's actually just an update on this that just got published this past week, which I don't have in here. But again, excellent outcomes. So this is an area that I have a lot of expertise in, and I've been doing it for a long, long time. So if you want to talk the history of protons, I think I know where, as they say, all the bodies are buried. So classically, we treated circles in circles. Pediatric tumors are kind of an exception because there's a big advantage for protons in peds because we reduce the non-target dose. But if you look at everything else that was historically treated, brain tumors, base of skull, spinal tumors, paraspinal, prostate, uveal melanoma, intracranial radiosurgery, really what they have in common is the geometry. It's a circle, and the reason that is because you had to use heavy, what we call brass apertures and compensators, and you really couldn't shape within a field. So there was no concept of this intensity modulation. You had to do everything forward planned, and as a result, that's why we got into these particular indications for so many years. It wasn't because these were necessarily the best cases, it's because we could actually deliver for decades and decades. Then along came something called pencil beam scanning, which is now the only thing we use. And that is like, imagine you have jelly beans and you've got to fill up an oddly shaped, the hydrogen ions are the jelly beans, and you can put them into any shape. And so really the advantage of protons is when the field is big or when the shape is odd. And so I'm gonna hopefully prove that to you with the example of whole pelvic radiation therapy. And so in full disclosure, this is something I've done. We were the first ones in the world probably to treat somebody with whole pelvic radiotherapy using what we call passive scattering, using the aperture compensators. This is from 2007. This was Bisham Chera. He was a resident at the time, which is a long time ago. And so what you're seeing here are the apertures. These are brass. These can weigh 30, 40, 50 pounds. So for those of you who know, the whole pelvic radiotherapy is essentially an inverted Y. The lymph nodes go alongside with the vessels, and so it's an inverted Y. It's a complex shape. And so this was what we call 3 isocenters, 6 fields, took 90 minutes. We were matching basically different beams from different angles in the mid-pelvis during this time. We treated 1 patient and we were done. And so I moved to Oklahoma City after this. We had an intermediary technology called uniform scanning. Bigger fields, greater depth, still needed apertures and compensators, but so we were the first ones. We treated this as a patient with anal canal cancer, but really the point on this is we were starting to get closer to using this for whole pelvic radiotherapy, and we decreased the small bowel dose by 60% and the bladder dose by 40%, and these patients we didn't do a randomized study. We just treated these patients prospectively on a single arm, but they did very, very well relative to my experience and historical. But now you get to pencil beam scanning, and now this is standard. Every proton center can do this. It's 2 to 3 fields, and it's very elegant, and you can see the difference in dose. These are color washes. And so you just have a very high efficiency of radiation delivery to the target volume with very little dose to the non-target. And so really the evolution that I've seen in my career going from, I guess over the last roughly 20 years, is we went from 6 fields to 60 to 90 minutes to 3 to 4 fields, 40 minutes, and now 2 fields, 25 minutes. We can spare all these non-target tissues. It's more practical and feasible. But the initial data does not support reduced toxicity with protons versus IMRT, at least for anal canal cancer. This was a study we did with a few other institutions with prospectively captured data. This is not meant to be an eye test, but really looking at grade 2 or higher acute toxicity and grade 3 or higher, and you can see the p-values are all kind of high. So this theory, at least so far, has not translated is not widely translating in this particular clinical scenario to decrease clinical outcomes and an improved clinical experience for the patient, but I think there's still work to be done. Protons for liver cancer, I think, is potentially one of the success stories. Again, liver is challenging because sometimes you can have some big targets and you have very sensitive tissue around it. So this is one of our earlier cases. And this is, by the way, there's fairly good data for this. And so it's in our Astro payer guidelines, it's in our Astro guidelines, and it's supported in most payer guidelines that you can use protons for liver targets. So this is one of the earlier cases we treated, a large HCC. This would be tough to treat with x-rays. We could do it. It would be very hard because you'd give a lot of dose to the healthy liver, and there isn't a whole lot of healthy liver here. So with a relatively simple 3-field proton plan, but this is a lot of volume. This would be if we did it with IMRT and a very good IMRT plan, and this is with protons, just 3 fields, and you can see the healthy tissue really gets no dose whatsoever. Now, this is, there's only probably, I'm guessing only my colleague, Dr. Stephen Lin, can understand, is appreciating this, but remember those jelly beans? This is about 120,000 jelly beans we've got to drop in the jar, and because these are called energy layers, it goes distal to proximal from different angles, but the first fraction, which is always the longest one because of setting patients up, was 120 minutes, and even the second fraction was 90 minutes. We do these, but this takes a while. And you can see the outcomes were pretty impressive. Going from pre-radiation to 6 weeks to 3 months to 6 months to 9 months to a year. So I think future directions, we want to personalize dose escalation. I'm glad to see we discussed so much on circulating tumor DNA and other things. I think that this is going to be an area where hopefully we adapt radiotherapy, adjuvant radiotherapy or adjuvant treatment. But we're not there just yet, but I think it's coming. See how we combine radiation, and then I think, again, the liquid biopsies are exciting for us. So with that, thank you for the invitation, and I appreciate this.